Okay, good morning. Welcome to day 2 of the Biannual Research Colloquium. It's a collaboration between Aspen University and United States University. And the entire week of the colloquium is made up of presenters who are our own faculty members here. And what the focus of the colloquium is related to the research that they've been doing out in the field, and them now coming to the colloquium and sharing some of that research with their peers and other individuals in the discipline, and even outside of the discipline, because this is open to the entire academic community, for individuals to be able to learn from the presenters and be able to interact with the presenter. So as part of this process, we hope that you take notes throughout the presentations, and then when we get to the Q&A segment of the session, then you'll be able to ask the presenter some questions. So I'm going to start off with Dr. Rhonda Winegar. She is our program director in Austin, Texas, and she is helping develop our pre-licensure program over there. But Rhonda has done some interesting research related to vitamin D and sleep patterns. So Dr. Winegar, I will just turn it over to you and let you begin.
All right. Well, thank you so much for having me. And I'm going to be talking about my dissertation topic. I just completed my dissertation and my PhD last year, and my topic was investigating the vitamin D levels and sleep quality. So this has got some complicated terms, and if at any time you guys don't understand, then go ahead and stop me. I can't see the chat box, so if you just stop me, that's okay. So I've got my timer going for 1 hour and we're going to get started. So as Dr. Thrasher mentioned, I'm the program director for Austin, Texas for the pre-licensure BSN program. I have both a PhD and a DNP from St. Louis University, and I'm actually so old, I have done all the nursing programs without bridges. So I started out as an associate degree nurse, and then I went back and got my bachelor's and then my master's, and I have a postmaster's certificate in education, and I'm also a nurse practitioner. So I've been a registered nurse for over 30 years, and I've been a nurse practitioner for over 20 years. I primarily practice in neurology. I'm a movement specialist, so I've done a lot with essential tremor, Parkinson's, brain stimulators, and I also have worked extensively in sleep medicine. So I've taken care of a lot of patients with obstructive sleep apnea, rapid eye movement, behavioral disorder, narcolepsy. For hobbies, I rescued 2 Scottish Terriers a few years ago, and they're actors. So they do commercials for a local air conditioning company. So we film commercials all the time, and they have a Facebook where they offer coupons for the air conditioning company. And my husband and I have a vintage RV. It's a 1967 Playmore. Its name's Emmalou. And we travel a lot all over and take our vintage RV. And we also have a red Harley Davidson, and we go all over on our Harley Davidson. And we actually dress up as Santa Claus and Mrs. Claus. And one of the practice sites that I work at is an inpatient behavioral psych unit. And the children are used to us driving by. We dress up as the Easter Bunny and, Mrs. Chicken. And so we do that as a community service. Okay. For the learning objectives for today's talk, the first one is I want you to understand the benefits of sleep and vitamin D. And the second one is I want you to identify the components, what goes into sleep quality, what are the components of sleep architecture, and how, besides having, sleep disorders, what all plays into a good night's sleep. We're going to start off with a pre-test. The first one that I want you to put in the chat box, and Dr. Thrasher will let me know some of the comments, is, do you sleep well? Do you think you get a good night's sleep? How many hours do you sleep? Do you have difficulty going to sleep? Difficulty staying asleep? Do you know your vitamin D level? Is it normal? Did someone tell you it was normal? Are you being treated for it? Were you supposed to be treated for it and you never started anything for it? So those are just kind of the thoughts that I want you all to be thinking about before we get started. So Dr. Thrasher, if you can let me know when there's some chats coming through.
Yeah, For me, I sleep like a baby is what I wrote. I don't have any problem sleeping, but I have no clue what my vitamin D levels are. I'm assuming I would need a blood test or something for that.
Yeah, you do need a blood test to find out your vitamin D level.
Yeah. And somebody did comment that they have vitamin D deficiency and is on supplements. That was Lorraine. And then Angela says that sometimes she sleeps, she struggles with sleep, but she's never checked her vitamin D. Some don't have very much quality of sleep on a regular basis throughout, many of the nights. They haven't checked their vitamin D. Some say they take 6,000 IU per day of vitamin D. Trouble falling asleep. Once they get to sleep, though, they sleep pretty hard, but they can't wake up on time.
Sometimes that
Or in the
inability
winter,
to
they think maybe they have some more deficiency in the winter time of vitamin D. Maybe it's exposure to sunlight, for example. Wake
and
up
that's a
at
good
night.
point. We'll talk about that.
Yeah.
But sometimes
Have a
that
quiet
inability to
room.
wake up. Oh, I'm sorry.
Not, they just have to have a quiet room. So it sounds like that we all have some level of sleep disturbance that, we're not perfectly have a solid night's sleep, it sounds like.
What I was
And not
going to
many
say is
people
some of
know their
that.
vitamin D. That's the general theme.
What I was going to say about that inability to wake up the next morning, sometimes you have such a difficulty going into sleep that by the time you get into the rapid eye movement sleep and that deep sleep, then that's your restorative sleep. And then it's time to get up and go to work. So at the very end, I'll talk a little bit about sleep hygiene, and I can open it up to questions because I've treated people with insomnia for years, and there's a lot of different things that we can do for sleep disorders.
Yeah, Rhonda,
Okay.
for me, I sleep well throughout the night, but I never dream. I don't remember having very many dreams.
Some people, and we'll talk about rapid
Okay,
eye
no problem
movement.
about that. Okay.
And that's where the dreams are. And some people just don't remember if they dream. And we can see on the EEG during a polysomnography and inpatient sleep study that you're actually in rapid eye movement sleep. And we can see with limb movement and everything that you're acting out the sleep or acting out the dreams. But when we ask people, they'll say, "Oh, I didn't sleep at all. I didn't have any dreams." So sometimes that's an objective matter or method, and we'll talk about that in just a second. But those are all great questions, and you can interrupt me at any time as we go forward. So for the introduction, insomnia, it's a pretty simple definition. It's trouble going to or staying asleep. And like we saw in the chat box, some people, have no difficulty going to sleep. Dr. Thrasher sleeps like a baby. Some people, need a quiet room to go to sleep. If, a cricket's rustling outside the window, they'll wake up. They have a really low sleep threshold. And some people can go to sleep immediately, but they're going to wake up all night long. And, it could be related to a lot of different things. It could be related to hot flashes. It could be related to chronic pain. Could be related to being on a diuretic, having to get up frequently to go urinate. There's a lot of different things that could impact your sleep. So there's acute insomnia, and that might be related to, I just had COVID and I've been coughing and sneezing and I can't get comfortable at night. So that would be an acute insomnia. Chronic insomnia is if it occurs more than 3 nights a week or if it lasts for more than 3 months in duration. And actually, the Center for Disease Control and Prevention said that 45% of the world's population has insomnia. So it is a big problem. On the other hand, vitamin D deficiency, it's very hard to quantify because it's not regulated across the nation. What's a normal vitamin D? What's a sufficient level of vitamin D? What's a deficiency? So we count a vitamin D deficiency as anything less than 20 mgs per milliliter. That's a deficiency. But then you have an insufficiency and you have normal levels. And we all know when we look at labs, there can be interpreted so many different ways. And then you also have to look at the lab that drew it and interpreted it. So regional labs can have different levels of standards and of ranges. For this study, the labs in Austin, Texas used a level of greater than 30 mg per milliliter as normal. So that's what we used for the study, is what the local labs used. But according to the National Institute of Health, anything greater than 50 is considered sufficient. So I want you guys to remember that as we go through on this study. So the local lab said, if you're greater than 30, check it, you're normal. But the National Institute of Health says, if you're greater than 50, you're sufficient. Not normal, but you're sufficient. So there's a great discrepancy there. And in town, doctors don't usually check vitamin D levels unless there's something going on. If you're a cancer patient, if you've got a lot of vitamin D deficiency, if you've got something wrong with your gut where you don't absorb vitamins. And it's really unusual to see a vitamin D level come through on a standard lab. And if you do, for some reason, get a vitamin D level, it's rarely treated. So I saw patients all the time that would, say, oh, my vitamin D level is low. The doctor told me to take something. He didn't tell me what to take. He said it was over the counter. And if we all went to the store right now, we would get all different. We might get international units. We might get micrograms. We might think there's enough in our vitamins, our multivitamin. So it's not standard for the treatment. And even if it's super low, then the doctor might say, hey, go ahead and take 2,000, units a day, but wouldn't recheck the level and would just document that they have a low vitamin D level. And when I started this research, I asked my primary for a vitamin D level, and they were like, you don't need that. There's no reason for it. And I said, well, I really want it. And they said, well, insurance won't pay for it. And I said, well, I'll pay for it out of pocket. And I went ahead and got my vitamin D level, and it was a 16. So it was low. And the doctor was like, that doesn't mean anything. Don't worry about it. It's probably your multivitamin. So I had to, be proactive and treat it myself. But think about how many people wouldn't be proactive. And the doctor, when you call and say, what are the results of my lab? Oh, everything was great. So a lot of times you don't get those results. So that's something to consider. And actually 1 billion people worldwide have been reported to have a vitamin D insufficiency or deficiency. So that's something that we really need to consider. And before COVID, they used to say that vitamin D deficiency was a pandemic. So keep that in the back of your mind as we're going through this. For the background of sleep, we all know that you've got to sleep good. You need it for your mental health. You need it for your physical health. Insomnia has been linked to lower immunity. It's linked to weight gain, depression, anxiety, high blood pressure. And they've also done studies and found that those that don't sleep well have a higher risk of mortality than those that do sleep well. And by a show of hands or going to the chat box, how many hours of sleep do you guys think is normal? And I was always floored when I would have patients come in and tell me they weren't sleeping good. And I would ask them how many hours of sleep that they needed. So I just want to take a few seconds and see what you all think is normal amount of sleep.
Yep, they're coming in 8 to 10, varies by age. Different people say I need 8, which means, whatever the standard is and what they need. Some people are saying 7 hours, 8 to 10 seems to be, around that time range. Does it have to be consecutive, Norma? So for example, if I sleep 4 hours and then get up for an hour and then go back and sleep 4 more hours, would that be considered 8 hours of sleep?
Okay, so actually,
some people say a minimum they can get by on 6 hours of sleep.
So actually, the National Sleep Foundation says 6 to 8 hours of sleep for adults. 8 to 10 hours is more for children and adolescents. And most people are under that thought that I need 8 to 10 hours of sleep. And I would get people that would come into the clinic and say, I'm just not sleeping. And I'd say, well, what time do you go to bed? Well, I go to bed at 10, when I get up at 8, I'm like, that's 10 hours of sleep. And they would want an Ambien so they could go to sleep at 9 instead of 10. So in Norma's question about, can I sleep an hour and then go back to sleep and get up? That's actually not a good restorative sleep. We'll talk a little bit about it when we get into sleep architecture, but you actually have several stages of sleep. You have 4 stages of non-rapid eye movement sleep before you roll into the rapid eye movement sleep. And you need about 3 to 4 of those complete segments of sleep to have a complete restorative. So there have been a few micro sleepers in history. It's like your Albert Einstein, your Picasso, those kind of people that, would sleep 2 hours and that's all they needed. But they would take power naps during the day. That's unusual. to have people that can, function on that kind of micro sleeping kind of schedule, but there are a few people out there that can get by with that. But typically you need 6 hours of sleep. And I did hear in the chat box that you said it fluctuates based on age, and that's absolutely correct. As you get older, you need less sleep. So if you take an infant, they're going to need a lot more sleep than a 65-year-old because, it's the growing process and metabolism and so many different things. But we'll talk more about that as we get into sleep architecture. But those are all great points that you brought up. And, a lot of people can be in bed and think they're sleeping for 10 to 12 hours, but they're actually watching TV on their computer, eating in bed. I can't tell you how many men tell me that they eat in bed. So, you're doing a lot of different things except sleeping. So while you may be in that bed for all those hours, you're not sleeping. Or, like Norma said, if you're getting up frequently, that's a fitful sleep and it's not a restorative sleep. So the next day you could be tired. So a little bit about the background of vitamin D. Vitamin D is a fat-soluble vitamin, and it's not easily obtained in present day. So it's not really available in a lot of our foods. You can get it in some fish. You all have probably seen in your cereal boxes that it says fortified with vitamin D. Whole milk will say fortified with vitamin D. But if you read on it, it says fortified with 400 international units. And I heard some of you saying in the chat box that you take 6,000 international units. So do you really think you're getting enough vitamin D in that bowl of cereal in the morning? Because you're really not. And why is vitamin D deficiency an issue now? Why suddenly is it become an issue? Think about how much we are told about how harmful the sun's rays are, how we need to put on sunscreen before we go outside, how we have to be so careful of melanoma. So we put sunscreen in everything. Women's makeup has sunscreen already applied. Think about our cars when we get out. Our cars have tinted windows. So we have so much protection from the sun. And it's very unusual that we go outside and are uncovered, with shorts, t-shirts, anything like that. We usually, make sure we've got on sunscreen or we've got long sleeves on. So, in present day, as compared to the 1920s when we were working in the fields and everything, we got a lot more sun exposure then. And we have people that work rotating shifts. We have people that stay inside and watch TV. We're not as active as a society as we used to be. And to put it in perspective, if you went outside and stood naked with no sunscreen, no clothes for 30 minutes, you would absorb 20,000 units of vitamin D. So that's how much you would absorb. Now think about that time you run out to your car, get in your car, you've got clothes on, how much vitamin D you're absorbing. So it's a big difference. So why is vitamin D deficiency important? Because it can impact the outcome of many diseases, including COVID. And right when COVID started coming out and they were talking about it, they found that there was a big link to vitamin D deficiencies. And they were finding that people of lower socioeconomic status and people that were darker skinned were having more negative outcomes of COVID. So we saw it more in our Native Americans, Hispanics, and African Americans were having that bad effect of the COVID. And one of the thoughts is, vitamin D is not absorbed with sunscreen, and it's also not as absorbed as readily for darker skinned people because the melanin is a protective layer of the skin that inhibits the absorption of vitamin D. So that's something to consider. Besides COVID, Alzheimer's, cardiovascular disease, cancer, chronic pain, diabetes, kidney failure, multiple sclerosis, those are just a few things that are impacted by low vitamin D. So some of the background of this research, why I chose this topic, it was an emerging topic of research. No one had studied vitamin D levels with polysomnography. So a polysomnography is an in-house sleep study. There's a lot of research done on home sleep studies. A home sleep study is where you show up to the doctor's office and we give you like the ET finger, a SAT probe, and you wear a microphone over your throat so we can capture how many times you quit breathing, how many snoring episodes you had, and that's pretty much all it tells us. An in-house polysomnography sleep study gives us much more, and we'll talk about that in a minute, everything that we're able to monitor. So the research had not been done with sleep studies and vitamin D levels. And I also included the Epworth Sleepiness Scale to evaluate for hypersomnia. And so we were looking at the Epworth Sleepiness Scale, an in-house polysomnography, and a vitamin D level. So I had objective measures as well as subjective measures, because the Epworth Sleepiness Scale is a scale that people can complete based on how tired they are in normal situations. So that was, the basis of all the research that I had pulled up. There was a lot of research done on, comparing genders, comparing races with sleep, ages of sleep, children and sleep, stress levels and sleep, but there was nothing done that had the vitamin D, the Epworth Sleepiness Scale, and an inpatient sleep study. So some things that we know about insomnia is it's more prevalent in older people. So older people typically have more insomnia, but one thing you've got to remember is reported. So if you're 35 years old, working a job, taking care of kids, you may not think it's important to take off work and to go in and talk to your doctor about your insomnia. But if you're retired, you're there for an annual visit, it's time to get your blood pressure, medicine refilled, you might bring up that you're having some insomnia, or they might ask you. So anytime that you read these type of studies, you need to always remember reported versus known. So it's been reported that women have more insomnia, and that can be because of gender roles. So at the end of the day, when the woman gets home, she has to make dinner, do the laundry, clean the house. Husband eats dinner, typically watches some TV and goes to bed. But the wife, the mother, is still checking homework, packing lunches. So, based on those gender roles, she may go to bed later, and she may get up earlier to get the kids ready for school. She may be a single parent. So there's a lot of things that play into that. If she's a single parent, she could have more stress trying to, juggle job, kids, everything. So those are some things you've got to think about. Again, minorities were found to have more insomnia than Caucasians, and lower socioeconomic status was also shown to be an indicator. And if you think about that, if you have food insecurity, if you have anxiety related to paying the bills, if you're working multiple jobs to pay the bills, then probably you're going to have more insomnia. Finally, sleep is very hard to quantify, and it's subjective. So Kevin told us, hey, I sleep like a baby. He may think he sleeps like a baby, but if we hook him up to, all the electrodes and the probes and put him in a sleep lab, we may find that he wakes up multiple times and he just doesn't know that he wakes up multiple times. Or we might find that he moves his limbs all night long and he has periodic limb movement. So there's a lot of things that you can find in a sleep study. And somebody just saying, I go to bed at 10, I get up at 8, I sleep pretty good. But you may be getting up all night long. You might be tossing and turning. So even though you're in the bed, you may not be sleeping. So that's very important to know that it's subjective. Okay, for the research question, I was looking to see, is there a relationship between vitamin D levels and sleep quality? Because we know that vitamin D levels and sleep impact cytokines, and cytokines work on inflammation and immunity. So there was a lot of speculation going back and forth that they might be related. In some of my sleep journals, they were talking about a potential, relationship. It might be known. Specifically, I was exploring the association between vitamin D levels and the sleep architecture descriptors of sleep duration, sleep latency, sleep efficiency, arousal index, rapid eye movement cycles, rapid eye movement latency, and the sleep disorder descriptors for obstructive sleep apnea, periodic limb movement, and hypersomnia. And these are my dogs here that I rescued. The one on the left is Bessie, and the one on the right is Bo. Okay, for a sample size determination, there were no published studies. I told you this was emerging data. There was nothing out there to base an effect size. So what did I do then? There wasn't any research. So What I did was I looked for a moderate effect size between vitamin D levels and sleep quality. I conducted an a priori power analysis with G-power 3.1 for a Pearson correlation, and estimated that the sample size needed to achieve a power of 0.80 with an alpha level of 0.05, and to avoid type 2 errors would be 128 patients. So in light of that, and there weren't that many patients, I said I was going to try to collect anybody that I could that would meet that inclusion criteria. So I was able to collect 137 patients. So I did meet that criteria. For the study site, I was working at a general neurology and sleep disorder practice that had an inpatient sleep lab on site in Austin, Texas. They do 200 sleep studies, inpatient sleep studies per year. That's important because they don't just do home sleep studies and they don't refer them out, they do them there. And for continuity and evaluation of sleep studies, you want to make sure that you're having the sleep studies read by the same people that are using the same methods of interpretation. And so we had that. We had two different board certified sleep specialists that were board certified neurologists that read them and interpreted them. And I said we did 300 sleep studies a year and we saw 7,000 patients per year. So they could be being seen for general neurology or they could have been referred over for sleep problems. And another thing to consider as we go through this population is these may have been patients that were already being seen for obstructive sleep apnea, Parkinson's, something like that. And they mentioned that they were having more issues sleeping. Maybe they had sleep apnea and they lost 10 pounds. If you lose 10 pounds, we repeat the sleep study because you may need an adjustment of your CPAP. You may need a different treatment. Maybe you don't need to be on continuous pressure anymore. You need to be on BiPAP. So we make adjustments and we see, what type of treatment to do. So you need to consider that as we go forward, that these were sick patients that came that already had sleep complaints and were already being seen in a sleep practice or had been referred for sleep or had general neurology complaints. So it wasn't a normal population being compared. So the sample was a convenient sample. As I mentioned, the patients that had presented to this clinic during the study timeline. And the study timeline was January the 1st, 2017 to January the 1st, 2019. I did 2 years because I wanted to make sure that I had enough time for to meet that power analysis, to make sure I had enough patients. And you have to be really careful to make sure that if you see a patient today and I order a sleep study, I'm going to have to get insurance approval. You're going to have to take time off work. You're going to have to find someone to watch the kids. So just because I order a sleep study in May doesn't mean you're going to have it done in May. I also have to check for availability of the sleep lab. We are very busy from October to December because everybody's trying to use their health spending accounts and they've met their deductible and they're trying to get in and get everything done. And they've got time off work and school, with vacation and everything. January to March, we don't have as many patients because people don't come in. They're all trying to catch up on their bills, trying to catch up on their time off. And so we don't have as many patients that time of year. So that's why I chose for that 2 years. Our inclusion criteria was a patient had to have inpatient sleep study during the time period, along with a vitamin D level that had been done within 90 days of that sleep study and documented. So the reason for that being so important is we mentioned earlier in the chat box that they can fluctuate. Your vitamin D levels are higher in the summertime when you're outside than in winter. So I don't want to do a sleep study based on your vitamin D level that you had several months ago that may or may not have been treated. And I only took them if they were documented. So we all know patients' memory isn't what it should be. It may have been 60 and they'll tell you 6. It had to be a serum level. It couldn't have been, they were at Whole Foods and someone said, you look pale, I bet you your vitamin D level's low. So I had to have a documented report from the lab done within 90 days of that sleep study. The exclusion criteria was no home sleep studies. I didn't look at home sleep studies, only the inpatient polysomnography. Again, the vitamin D levels done within 90 days and documented, and that, they presented to that clinic during the time frame. So we did look at 137 patients. Again, these were general neurology patients or patients that presented with sleep complaints. For the measures that we looked at, I looked at the polysomnography, again, the Epworth Sleepiness Scale, which I'll show you in just a little bit, and demographics of the sample, as well as the serum vitamin D levels, and I'll expand on what demographics I pulled from the electronic medical chart. So in the polysomnography, as you can see, this is a man hooked up, ready to sleep. Do you guys think that you could sleep pretty good like that with all those electrodes and probes? And, we've got everything, we've got electrodes hooked up to all of your limbs. We have that microphone under your chin. We have a full EEG on. We have belts on to measure lung expansion. So there's a lot on there. And to add to your sleeping comfort, we also have a camera on you. And anytime that you move or an electrode comes off, either the attendant's going to come in the room or he's going to speak over the microphone. So kind of think about that while you're hearing some of this. So do you think sleep would be harder in a sleep lab? And actually, I know you guys aren't going to believe this, but people will all say that was the best sleep of my life when I was in that sleep lab. And if you think about, they don't have any kind of responsibilities. They don't have to think about, oh, I'm afraid I'm going to oversleep tomorrow and be late for work, because they typically take off the next day. They don't have to, get the kids up. They don't have to worry about caring for that mother that's in the next room. I've had patients that said they set the alarm every 2 hours to get up and check and see if their cat died. And I said, well, what would you do if your cat died? Well, I'd put her body in the garage. And I said, well, what would be different than if you just waited till the morning and saw if the cat died? But people will wake up for the silliest things all night long. I had one woman who stayed up all night and quilted in the bedroom while her husband tried to sleep, because that's where the sewing machine was. So she would sew all night with the lights on while he was trying to sleep. And I said, why don't you move your quilter into the living room? And they had never thought of that. So he wanted me to give him Ambien so he could sleep better. So a lot of times it's little things like that that people don't even think about till you bring it up. So for the sleep architecture descriptors that we look at with a sleep study, the first one is sleep duration. How long did they sleep? And we can tell with the EEG when you go to sleep. And like we mentioned, normal is 6 to 8 hours, but for sleep evaluation, we typically say 7 to 9, based on age and everything. Sleep latency is how long did it take you to go to sleep? And anything less than 30 minutes is considered normal, but we look at the time of lights out to time you go to sleep, because we understand if you come into a sleep lab, you might be milling around in the bed, reading the Harlequin romance, talking on the phone. So we don't add up that time. We add up the time lights out to when you go to sleep. So less than 30 minutes is normal. Sleep efficiency is the time spent in the bed divided by the time spent asleep. Again, if you're messing around in the bed, reading a Harlequin romance, we're not going to calculate all that, but we do have a chair in the sleep lab, and we do have, a computer set up if you want to do things like that. And then once you get ready for bed and get in the bed, that's when the calculation starts. And also, we don't have people show up to the sleep lab at 6 p.m. We set up times of like 9:30, 10, and 10:30 arrival times, because we don't want to be looking at you while you're getting ready for bed. So we need about 30 minutes to hook you up to get you all ready for that sleep. So that's why we have those those arrival times. And, typically when people come into a sleep lab, they've already taken a bath or a shower. They bought the new, pajamas at Walmart. They've got everything ready to go. They've taken their meds. They're ready to go. versus at home, I think I'll get ready to bed. Oh, I forgot to start the coffee pot. Let me go get in there and get the coffee pot ready. So these people, that might be why they sleep better in the sleep lab, because they're ready to go to sleep. Then, and on the arousal time, anything greater than, or I'm sorry, sleep efficiency, anything greater than 85% is good. Arousal index is how many awakenings do you have an hour? Again, arousal index could be I'm in rapid eye movement sleep, having dreams, and then something happens and I arouse a little bit and I go into one of the other stages of non-rapid eye movement sleep. It's not a arousal where I'm going to get up and go to the bathroom or anything like that. It's just where I wake up a little bit. So less than 5 an hour is normal. 5 to 14 is considered a mild sleep disturbance. 15 to 30 is moderate, and greater than 30 is severe. The next thing that we look at is the number of rapid eye movement cycles. You should have 3 to 5 a night. And I said it takes about 120 to 150 minutes to cycle from NREM into REM sleep. So for rapid eye movement latency, since I said it's like 90 to 120 minutes to get from NREM into REM, and depending on how many cycles you've had and how many arousals you've had, we consider anything less than 150 minutes to be normal. In order to have a restorative good sleep, you need to have multiple segments of moving through all these sleep cycles. So you need to have, like that 3 to 5 rapid eye movement cycles a night. And if you have more than that, because some people think, oh, wow, if I need 3 to 5, having 8 to 10 would be wonderful. No, because then that would be narcolepsy. So if you have multiple REM cycles, you're not phasing through those cycles of NREM, you're going straight into REM sleep, and it's not a restorative sleep. Okay, now we're going to talk about the sleep disorder descriptors that are brought up in a sleep study. The first one is obstructive sleep apnea. We look at the apnea-hypopnea index, and apnea is defined as a pause in breathing that lasts at least 10 seconds and causes a decrease in saturation. In hypopnea, we have those belts on to tell if you're shallow breathing, rapid breathing. And so that's looking for that. And people say, well, you know what? I was flipping over in bed, so it didn't catch me. That's why we say it's not sleep apnea if it's less than 5 an hour, because we do add some of those considerations into there. So 5 to 14 apnea-hypopneas an hour is a mild sleep apnea. 15 to 29 is a moderate. Greater than 30 is severe. And I have here a picture. So this is a normal person sitting upright, and here's their airway, and you can see their tongues right here. So if you're sitting upright and your tongue's laying in the bottom of your mouth like that, think about when you lay back and you put your head back, your tongue will kind of roll back. So a normal person, their tongue will still, it'll lay back, but it's not going to completely close off their airway. It's relaxed and the air can still flow from their nose and their mouth straight through. When you get snoring, it's because that tongue's partially blocked that airway and it's causing a vibration. That's snoring. So it's partially blocked. And hang on. Let me go back in. Sorry, I hit the wrong button. Okay. Okay, so if it's a completely blocked airway, though, that tongue has completely rolled back and blocked that airway. And those are the people that'll say, I wake up all the time and I have a dry mouth, because you're a mouth breather. And it can also be because they go, because they gasp and they wake up. So the next thing that we look for is periodic limb movement. And we have electrodes put on all of your limbs counting that movement. And, we understand that people are going to roll over in bed. They're going to reposition it. We don't count that as periodic limb movement. The criteria for leg movement to be counted is that movement must last at least a half a second, no longer than 10 seconds per event. So if you have a tremor because you have Parkinson's, it's not counting that as periodic limb movement. And it's also got to have a minimum amplitude per event of 42. and an 8-unit voltage increase for us to count that limb at rest moving. The minimum amount of periodic limb movement to constitute a series of events is 4 per hour. So if it's like 3, we don't even count it. We start watching it more if it's 4. So 2 different leg movements, if I'm moving my right and left leg at the same time, that will only count as 1 periodic limb movement. So severity is determined by the amount of periodic limb movement. Greater than 5 is normal, because we know you're going to, move your body and turn. 5 to 24 is mild, 25 to 49 is moderate, and greater than 50 is severe. For hypersomnia, we also look at how quickly you go to sleep, the rapid eye movement cycles you have, how long it takes you to get into REM sleep. And then if we're looking for something like narcolepsy, we'll count those rapid eye movement cycles. And then the next day, we'll have you stay over and take a couple naps and count those as well. Okay, so this was that slide that really wanted you to jump to the front and look at it, kept popping up there. So this is the Epworth Sleepiness Scale. And when we have a new patient, we have them fill this out in the waiting room. It's very easy to fill out. It's got a scale of 0 to 24, and a 0 is I would never doze off under this situation. And a 1 is maybe there's a slight chance. 2 is a moderate chance. 3 is a high chance that I would doze off. And these situations are, I'm sitting and I'm reading, watching TV. I'm sitting inactive in a public place, like watching a movie. I'm just sitting there talking to someone. I'm sitting after lunch, but I didn't have alcohol, or I'm stopped in a car for traffic. So a score of 0 to 7 is you don't have abnormal sleepiness. 8 to 9 is average. 10 to 15, it's excessive depending on your situation. You may want to seek medical attention. Finally, if it's 16 to 24, you're excessively sleepy and you should consider seeking medical attention. This is some of the demographic samples or demographic descriptors that I collected from the population that we looked at. We collected age because, as we said earlier, older people have decreased sleep. We collected gender because females were reported to have more sleep. We collected race because minorities have more insomnia. We collected the body mass index because it's been reported in the past that those with higher BMI have less sleep. And it's also been reported that higher BMI have lower vitamin D levels. So that's why we looked at that. We collected marital status because being single, being married can affect your sleep. We looked at employment. Were they retired? Were they students? Did they work part-time? Did they work full-time? And we collected maladaptive coping mechanisms if they were on the chart. So if they used alcohol, because a lot of people will drink alcohol, I need it to help me wind down. I had a busy day. So it's going to help you go to sleep, but it's going to be a fitful sleep and it's not restful. Or did they use tobacco and caffeine? I'm so tired the next day that I have to smoke 2 cigarettes and drink coffee all day to wake up. So that's going to affect your ability to go to sleep the next day if you're wired on caffeine. So that'll affect your sleep latency. So we also collected herbals, napping, and exercise patterns. Do you exercise? Are you sedentary? Do you nap all day? Because if I take 2 naps a day, I'm going to have difficulty going to sleep. We collected their diagnosis, their presenting diagnosis, and their comorbid diagnoses. We collected medications, hypnotics, antidepressants, diuretics, benzodiazepines, opioids, stimulants. They can all affect your ability to go to sleep. As I mentioned, we collected the serum vitamin D levels. Again, there's no real normal level of vitamin D. It's varied based on the region that you live at. It can fluctuate during the year. It's rarely ordered, and it's not always treated, or if it's treated, it's not treated aggressively, and it's not usually followed up on. Again, as I mentioned, a vitamin D deficiency is defined as a serum level of 25 hydroxy vitamin D concentrate of less than 20 mgs per milliliter. Again, this lab for the study site accepted a level of 30 to 100 as normal, but the National Institute of Health said you've got to be greater than 50 to be sufficient. The time frame for the study was January 2017 to January 2019, with January 1st to January 1st being that timeline to allow a greater amount of patients to get insurance approval, get admitted, get in there, get their sleep studies, gave the doctors time to evaluate it, got everything scheduled, labs. A lot of times you'll give a patient a lab slip, they'll forget about it. You'll see them, did you get it? No, I didn't get it. Can you go and get it? They might get a vitamin B drawn instead of vitamin D because they didn't understand what you wrote. So we allowed for that time frame to get that done. This was a cross-sectional design with a retrospective chart review of the electronic medical records of those patients that met inclusion criteria. Data analysis. I use parametric and non-parametric analysis. For my categorical variables, I use descriptive statistics, primarily means and standard deviations, and I described them in tables. I was assessing for relationships between vitamin D and sleep quality, sleep disorders. So I used correlational analysis, parametric and non-parametric. I used regression analysis to evaluate further relationships with the polysomnography and the Epworth Sleepiness Scale. And finally, I used t-tests to evaluate to see if there was a significant difference between the two vitamin D levels of low and normal. So here is the baseline characteristics of the sample. I had 137 patients. They were generally middle-aged. I mean, their mean age was 57.8. They were primarily female, 54.7. They were mostly married, 41.6. Overwhelmingly, they were Caucasian, 60.6%. They were mainly overweight and obese. They had a mean BMI of 30. And overweight BMI is 25 to 29.9, and obese is anything greater than 30. So that kind of puts it in perspective for you. And we had a range, if you see here, on the BMI of 18 to 62. So it was quite a wide range. And remember, we treat attention deficit at this facility. So they may have already been on Concerta or Adderall. They could have been 18. They could be a college student. And part of the ADHD workup can include a sleep study. So we had some skinny 18-year-olds in this group. The majority, 73.7%, were not on vitamin D supplementation. So 73.7% were not on it. While the patients had a range of vitamin D levels of 5 to 63, the mean was 32.2. And the majority had seemingly normal levels of vitamin D based on what the study, sites, labs said, but 45% of those had below normal. So let's put this into focus. 61 of our patients, 45%, had levels below 30, which was considered low for this study, but only 12, 8.8, had levels greater than 50, which is considered normal by the US Department of Health. Therefore, 125 or 91.2% of our patients had low vitamin D levels because their mean was 32.2, and the majority, 73.3, were not on vitamin D. So to talk a little bit about the sleep quality descriptors, their sleep latency was 24.1 minutes. We know that sleep latency increases with age, but anything less than 30 minutes is considered normal. 26 patients, though, 5.3%, required more than 30 minutes to fall asleep. Their sleep efficiency score was 79.7, and remember I said greater than 85 is considered normal. And this was calculating by dividing the number of minutes spent asleep by the total minutes spent in the bed. Their arousal index was high at 30.5. So we said 5 to 14 was mild, 15 to 30 was moderate, and greater than 30 was severe. This range was 0 to 125. So some of them had 125 arousals. However, an arousal index of like 16.5 is considered normal for 41 to 50-year-olds, and 21.9 is normal for 51 to 60-year-olds. So it was still high. Sleep duration was 318.4 minutes. So that's 5.5 hours. And the National Sleep Foundation said 7 to 9 is good if you're 18 to 64. So it's kind of almost normal for middle-aged people. For the number of rapid eye movement cycles, they had 2.1. We know the number of REM cycles decreases with age, and 3 to 5 is normal for all age groups, including middle-aged adults. So they didn't have enough REM. REM latency was 150.8 minutes. So they're a little over at the normal of greater than 150. And like I said, it can typically take 90 to 120 minutes to cycle through all the non-rapid movements, eye movement, to get to rapid eye movement, which is the most restful and where the dreams are occurring. So overall, we had poor sleep quality in these patients, but the sleep architecture was kind of descriptive of middle-aged adults. Next, we're going to look at our sleep disorder descriptors. Now, remember, these patients, they were already at a sleep clinic, so they might have already had, a sleep diagnosis, and they were being evaluated for sleep complaints. So they may have already had sleep apnea and just lost some pounds, lost 10 pounds, and didn't respond to treatment. So you got to keep that into context. For periodic limb movement, only 4.8% of them had walked through the door with a diagnosis of periodic limb movement prior to the study. 14.6 movements was the average amount per hour, and it indicated a mild periodic limb movement. But while it's mild, periodic limb movement can contribute to the sleep arousals, and the patients were noted to have an average of 30.5 an hour. So it could have been caused by them moving their extremities during the night. For the obstructive sleep apnea, this is the important one. 43.1% walked through the door with a diagnosis of obstructive sleep apnea that had been diagnosed prior to the study. So the average hypopnea index was 18.1. And you've got to remember, typically they don't have a CPAP on. These were just sleep studies. So we already knew they had sleep apnea, and we took the CPAP off to see how it was doing without the treatment. So they quit breathing 18.1 times an hour. And that's a moderate sleep apnea. And remember, anything greater than 5 is considered sleep apnea. On the Epworth Sleepiness Scale, 6.6% of them had showed up with a diagnosis of hypersomnia. And, they also could have had the attention deficit or another reason that they were taking a stimulant like Adderall or Incerta, but 6.6 of them already had hypersomnia. These patients overall did not exhibit daytime sleepiness, and their average Epworth Sleepiness Scale was 7.1. So remember, 0 to 7 is considered normal, so they were pretty normal. But we have them hold their stimulant prior to the study, so they typically hold their stimulant 3 days before the study. So that could have had some kind of effect. And again, if we were evaluating for narcolepsy, I would have had them hold a stimulant for 3 to 5 weeks, and they would stay over the next day and do a nap study for multiple sleep latency to look for their narcolepsy. We also collected some confounding variables, and these are things like age, BMI, and gender, because we know these affect sleep. And, the research before had told us that age can affect sleep duration, sleep efficiency, sleep latency. So we did Pearson correlation to look at that. And it was found that as BMI levels were noted to increase, vitamin D levels were noted to drop, but we didn't really find any significant relationships between vitamin D levels and sleep quality and the demographic descriptors besides that. Okay, we did find a negative relationship between napping and vitamin D levels. And there's a lot of different things that can affect your sleep. I mentioned alcohol, tobacco, caffeine, hypnotics. So if someone takes Tylenol PM, Benadryl every night, and you'd be surprised, so many people take Benadryl every night to go to sleep. If they nap, if they continue to nap, that'll increase their insomnia. All of those will. But interestingly, 79.6% of the patients denied using tobacco. 60.6% denied using alcohol, but they overwhelmingly endorsed the use of caffeine daily. 59.1% said, yeah, I have to have caffeine. And this was found to affect their sleep latency. And 67.1% said they use sleep aids, either prescribed or over the counter. So 67.1%. Finally, a little over 40% indicated that they napped at least twice a week. and 24.1% said they napped at least once a day. So we did find a negative relationship between napping and vitamin D levels. As vitamin D levels went down, the patients reported more napping, but no other relationships were seen. What does all this mean? I gave you a lot of information. So in summation, the findings didn't support a significant relationship between vitamin D levels and sleep quality and sleep disorders, but they did indicate that the majority of our patients had low vitamin D levels despite the normal levels with the regional lab, and they all had poor sleep quality. We also found that they walked through the door with several sleep disorders that could have contributed to that poor sleep quality. Finally, our patients had problems with sleep quality that could have been related to their high BMI, their maladaptive coping mechanisms, using the sleep aids, drinking that coffee, napping, and not exercising. So in summary, I just wanted you guys to all understand the benefits of sleep and vitamin D. I hope that you understand that, and to identify the components of sleep quality, and specifically the sleep architecture descriptors of sleep duration, sleep latency, sleep efficiency, arousal index, number of REM cycles, rapid eye movement latency, obstructive sleep apnea, apnea-hypopnea index, periodic limb movement, hypersomnia, Epworth Sleepiness Scale. So now I want to take a few seconds and see if you want to change your pretest. If you haven't had your vitamin D level checked, you want to get it checked now? Do you think you sleep good after hearing this? So Dr. Thrasher, tell me what they're putting.
All righty. While they're sort of thinking of a response to your answer there, Dr. Winegar, I'm going to answer your question as well, and that is, there's a whole bunch of information that you just provided, and some information sort of seems like it fits my pattern and some doesn't. So one thing that I believe comes out of this, and you talked about something very important, which was a new concept to me, which was sleep architecture. And I really like that idea, but that everybody's sleep architecture is somewhat different. And some architectures, while they might not be appropriate for one person, they could work and be appropriate for another person. And so while I said that I sleep pretty soundly, I'm sure, and I do know I wake up frequently throughout the night, but I immediately go back to sleep. It's not disturbing to me enough, to prevent me from feeling rested in the morning. And I never take a nap. I'm one of those people that once I wake up, and you know me, Rhonda, you've interacted enough with me, that once I get up, I'm full blast. I'm in overdrive 100% until the moment I go to sleep, and then I just go sleep. And I don't have to nap during the day. Although I have noticed my pattern has changed a little bit since the pandemic, because now I telecommute as opposed to having to commute in a car and have an extra hour, that you got to build into your day to get to work. And then all the stress and et cetera of doing that when you come home. But I think the biggest pattern for me related to reflecting on what you've taught us today is in relation to sunlight. And I literally am someone whose sleep patterns are controlled by sunlight. And so I wake up without an alarm clock every day as soon as sunlight comes into my bedroom. And that's when I know exactly why the sun comes up, which is about 6:30 right now. During the winter, it was about 7:30. And now, in the middle of our summer, it's about 5:30. And that is when I wake up. I don't need an alarm clock. And it's the same on the opposite end of the day. Obviously when it goes dark earlier in the winter, I can look up at 6 or 7 or 8 o'clock at night and think I'm ready to go sleep, even though I might not be really tired. It's just as a mental thing, but somehow my sleep patterns are related to the sunlight. So those are some of my reflections.
Before you go further on that, I just wanted to say real quick, you're absolutely correct. And we actually have people that have been shift workers that have to take melatonin because they don't have that stimulus of the sun coming up. And so we'll actually tell people to reset sleep clock. And there's been lots of studies on that, you can go camping for a couple of days to have that stimulus of the sun coming up to help you reset your biological clock to wake up. but you're doing absolutely the right thing. And, we didn't have a lot of insomnia in the 40s and the 50s. What made insomnia much worse was the television. And, even when we first got TV, it would cut off at like 8 o'clock, but now it's available 24 hours a day, 7 days a week. So you can click on that TV, you can watch it in bed. And so people prolong their time up, or they watch TV in bed. But we always say the TV is our bread and butter, because if we can get that TV out of the bedroom, people sleep much better. But all those points you brought up were excellent.
Yeah, I think a lot of it is sort of stimulus and response. We are in some ways Pavlov's dog. And so if every night at 10 o'clock, we watch the news, and at 10:30 when the news goes off, we go into the bedroom and go to sleep, you do that enough, and that news will immediately put you to sleep, and you won't have problems, and you sort of mentioned that don't do a bunch of stuff in the bedroom that isn't meant to be done in the bedroom.
So when I have someone that has insomnia, I tell them to develop a sleep routine and to do 7 things, because your mind has to start winding down and getting ready for bed. And it can be little things like I'll say, set the coffee pot, lock the front door, throw the dog out, bring the cat in, wash your face, put on your pajamas, set the alarm. And as you start doing that, your body says, wait a minute, Rhonda always sets the coffee pot. I think she's getting ready to go to bed. And so everything starts winding down. But what happens is people say, oh, I got to watch TV or else I can't wind down. Really, because your mind is already starting to cycle down, and then you're watching the news and you say, hey, that lady has on a red dress. I have a red dress. So then you start firing different areas of your brain. You go, what I do know about a dress is I need to go to the dry cleaners and pick up my dress. So then you start firing other areas of your brain, and your whole brain starts waking up instead of cycling down. So you're stimulating your brain at night, watching TV in bed. So those are excellent points that you brought up. But you have to do something 7 times for it to be a habit. So that's why I usually say a sleep routine has to encompass 7 things. And then you just tell your brain, this is my sleep routine, and I'm starting my sleep routine and winding it down.
Okay, so
And
if
you're already a sleep
I got
expert.
to do something 7 times for it to be a habit, then I can only smoke 6 cigarettes and I need to stop, right?
Yeah.
Okay. Well, luckily I don't smoke, so I'm good on that. But one thing that I do want to add to that, and then I'm going to get into people's chats, is I do exercise regularly. And I also don't eat much processed food. I mean, I rarely, especially being home now, I can eat, a healthier cooked food. And that I have noticed since I've become a telecommuter. My sleeping seems to be, more effortless. Well, in the past, I would crash and wake up tired in the mornings. And so I think some of those changes have helped me. All right, let's get into some of the chats here.
Well, before you go with that, let me
Go
just
ahead.
say one thing. When you exercise, it's good to exercise in the morning. Do not exercise at night. If you're going to exercise at night, make sure it's at least 2 hours before you go to sleep. Because in order to go to sleep, a few things have to happen. Your body temperature has to go down a degree, your serum cortisol has to go down a degree, and your melatonin level has to go up. So if you go and do a real vigorous workout, going to cause your body temperature to go up, your cortisol level to go up, and your melatonin level to go down. So that's going to affect your ability to go to sleep. So never work out right before you go to sleep.
All righty. So Lorraine did confirm that she one time was in a sleep lab and she did sleep so much better there than she did at home. Yvette says that she takes vitamin D and she does sleep well as a result of doing that. Jennifer has a question. What is the cause of a large body jerk right before falling to sleep?
So first off, let me go back to Lorraine. She said she slept better in the sleep lab than anywhere she's ever slept. So if I have a patient that has insomnia and they can't break that cycle, I'll actually have them sleep in a guest room or go sleep in your kid's room, because that little thing, your brain is very easy to trick. And that's why you sleep so good on vacation, because it's a new environment. So actually, if I have insomnia and I'm trucking on back to my bed and my body's going, Rhonda, you're not going to sleep good tonight. You never sleep good tonight. We're just going back to the same old bed. I know we're not going to sleep good, but just mixing it up and trying a different bed can sometimes make a huge difference. So back to Jennifer's question, when she said sometimes she goes, it could be a lot of different things. So it could be a little bit of sleep paralysis. It could be a hypersensation. It could be rapid eye movement. It depends on, REM behavioral disorder. That's the people that punch in their sleep and hit people and, doing things like sleepwalking, sleep talking. Those are, we call them parasomnias. They're abnormal events. So I would need more information, Jennifer. Like, does that happen when you've been in bed for 30 minutes? Does it happen I just lay down? It could be a cataplexy. It could be many things, but knowing you, I would say, and, not having a full history, I would say it's a parasomnia, which some of us will have that when we're in bed and we are just about to fall asleep and we feel like we fell. That's just a parasomnia, and they're normal. You're just so relaxed and you're in probably your third stage of NREM sleep, and then you arouse and come out of it. But it's a parasomnia. If you have a lot of them, any time of abnormal behavior like that, we have you take melatonin. And, for the people that sleepwalk, sleep hit, all of that kind of stuff, we just do melatonin 1.5 or 3. And if you mix it with a magnesium, it's a better delivery. But if you go to the store, it's always 10 milligrams. That's way too much. No one needs 10 milligrams of melatonin. Did that answer your question, Jennifer?
And Jennifer, by the way, will be our next presenter today at our second session. So please, everybody, show up for her presentation as well. I do have a question about that big jerk body effect. It seems like when that has happened to me, it's almost like within seconds I've gone into REM sleep. And it seems like the jolt is like all of a sudden, it's like, wow, I all of a sudden was dreaming and it was 2 seconds ago when I was awake, And so, like you said, maybe I'm just so relaxed in the startling.
So you're actually paralyzed during REM sleep. You can't move. You're like purposeful movement. And so sometimes when you come out of REM back into an NREM, you get control and you jerk back, but it's just a parasomnia. And that's what I said. If you had narcolepsy, it happened during the day. Those people have cataplexy. And what that is, and I always describe it as, a lot of people think, oh my God, that means I'm going to completely fall out. No. And I say, if you're in a bar and a pretty girl walks by and you really want to give her your phone number and then you go to get up and you have no energy, or if you're fishing and you've got a real big fish and you're about to pull it in and then your hands just slump, it's just like a release. So a lot of people think cataplexy is just where I'm standing and then I pass completely out and go into a coma. Cataplexy is just like a relax. So a lot of those people can wet themselves. They can be sitting and then in a time of hyperexcitation. Like I have one woman that she always has cataplexy when she's about to get up and whip her kids. Like if her kids are really acting up and screaming and she's just about to jump up and go get them, just like collapses. So that's a little bit of
sheep. You scare those sheep and they fall over.
Yeah, fainting goats. Yeah.
Jennifer did have a follow-up to that, Rhonda, and that is, what is parasomnia?
Parasomnia just means anything that's abnormal when you're asleep. It's a catch-all term. So we call parasomnias like sleep paralysis, sleepwalking, sleep talking, hitting in sleep, all of those. Until we do a sleep study and capture that event, it's a parasomnia. So we don't know what's causing it, and that's just the catch-all term.
Yeah. Some things in the chat box are just comments, but they may, give you information. But Lorraine says that she had her vitamin. I hope I'm not violating HIPAA. But she said her vitamin D was drawn. It was a 20.6. But it was better than the previous of a 10, which was 6 months prior. And so she's going to go get it rechecked. So that might not be in the range.
So Lorraine, so with that, I would go back to your doctor, and typically, we all treat differently, and I'm not your provider, so I can't treat you, but I treat anything less than 20 aggressively. I typically do a 5,000 daily of vitamin D, and then I recheck it in 3 months. But, they may want to do 2,000 daily and then repeat it. And
I think Lorraine was one of the folks in the beginning who said she's taken 5,000 or 6,000 IUs as a supplement today because she may have a history of this deficiency.
And, I've taken 5,000 daily because of COVID, because it increases your immunity. And, since I see patients with COVID, I have not tested positive, but it's just something that I do. My last level was 94. And, high levels of vitamin D, there's not really a lot of side effects unless you get in those mega toxic doses, but you do need to make sure you have a level and discuss it with your physician before you adjust it.
Okay, very good. And Anne Marie, thanks you for the information. She does now helps her see what is normalish, I guess, in terms of sleeps and schedules. And she also did like that concept of sleep structure. Donna appreciates the lecture and says thank you. But she also is lucky she had her vitamin D drawn a couple of weeks ago. She knows what that is. She is on a supplement. And she says she's reading a wonderful book called Why We Sleep. And she loved hearing your lecture and then the science behind, the sleep medicine. So I don't know if you've ever heard of that book or not, Rhonda, but more thank yous. Okay, and then Angela has a question. Have you looked at melatonin to help with sleep and how that interacts with vitamin D? And you did mention a little bit about melatonin.
So melatonin, it interacts more with your body temperature and your cortisol level. So, I mean, my dissertation was 176 pages, so obviously I couldn't cover everything in that hour. But no, we looked at it. There's so many different ways to check melatonin, and the gold standard is a spit test, where you have them spit and then you have to freeze it, and then you had to have so many. And we looked at, and it was just too cost prohibitive to do for this study, and the patients would not want to absorb the cost. And that's not standard evaluation in a sleep study, but that is a great recommendation. And I did look at that, but did not because of the cost and because of the storage. And we would have had to buy a separate freezer and not have anything else in there and have it, regulated and all that. But that is a great point. We did look at it, but primarily the research on melatonin's been done with older males and co-occurring depression, anxiety, and insomnia. So I looked at that, and I wanted a more broad study, but great suggestion.
And then Jenny, Dr. Erkfitz, she again thanks you and says nice job on that. She enjoyed the study. And then she says it'd be interesting to see how much someone's vitamin D level fluctuates between winter and summer. And again,
so there's actually studies on that. And the take home point was they saw a fluctuation in 37% of the population, and it would fluctuate 4 to 8. So it wasn't a huge amount, and it was only seen in 37% of the population studied. And again, some of those study samples were smaller, like, 42 patients, 50 patients. So it's known, but it's not huge because of the sunscreen factor. And, the further you get away from the equator, the more vitamin D deficiencies that we see. So that's why multiple sclerosis is so much higher in northern climates because of the vitamin D absorption. So there's a lot of different things to consider there, but that is a good point.
Yeah, and you touched on Donna's comment, which was a follow-up to Jenny's, where she said it would be interesting to also do this kind of research in different geographic regions. You can see how the effects.
Those were the recommendations for my study. Is actually I would do a broader range of age groups. I would do a broader range of ethnicities, and I would include more males. And you got to think about males don't typically report as often as females for their annual visits and sleep complaints and that kind of thing. But yeah, definitely recommendations for future studies would be more ethnicities and genders and age groups and groups of normal patients who do not have sleep complaints and sleep disorders. But you have to remember a sleep study is $1,700, and that does not include the first visit to get the sleep study ordered. That's not your vitamin D level. That's not the follow-up to discuss the results. So you have to think about socioeconomic status too. And, you may not have met your deductible. You may not have insurance. So those are things to consider when you're bringing up those other wide ranges is who would qualify for a sleep study if they did not have a sleep complaint.
Okay, very good. We're coming up on the quarter of an hour. And so at the half of an hour, we have our second session for today. So I know Jennifer is in this session and want to give everybody else also the opportunity to take a bathroom break or whatever before the next one if they need to. Dr. Winegar, thank you so much for sharing this information. I mean, what an incredible invaluable piece of information that we all can benefit from. And probably for those of us who have been maybe suffering from sleep issues, the last thing we ever would have thought of would have been vitamin D. We would have
Well,
we would have
thank
thought
you
it was
for having
something
me.
else. Yeah. So
And if you have any questions, certainly email me, and I've got my contact information there as well.
it is aspen.edu, by the way. There is a U on the end of that.
Oh, I'm missing a U.
But that's
Sorry.
okay. Everybody, that would automatically hit in our systems as edu. But everyone else, have a good rest of your day. Thank you again, Dr. Winegar, and we will post this recording on the website soon. Take care. Talk to you soon.
Talk to you soon.